Okay, so we've covered this stuff pretty well, but we'll try to do some cases and try not to belabor the point too much, but the decision-making is really a large component of this whole process. Okay, there it goes. Okay, so this is a skeletally immature female who's had medial-sided pain for several months. She comes into your office. She has no swelling. She plays soccer. I believe she's about 12 years old, and so she has several years of maturity. She just had her menses, and she still has quite a bit shorter than her mom, so probably still some time of skeletal immaturity. And what would you say, just as an initial thought about this, how would you describe that lesion, and how would you talk to the family about this? And would you get an MRI right away? What would your next steps be? So you can go ahead, Jeff.
How long did they have pain again?
A couple months, 2 to 3 months.
I would typically I would get an MRI in this just to better define it. I think based on that X-ray and the medial femoral condyle, you're seeing already some cystic change a little bit behind that, which probably isn't fantastic for her. But again, in a 12-year-old, it's really difficult to tell where this is going to go because it could go so many directions from this point. But essentially, I would be talking to the family about the fact that a lot of people have these, a lot of people do really well with them, that doesn't necessarily mean that they're going on to surgery and that they're going to have a knee replacement when they're 20. There's good results with this, but MRI and then starting to talk about conservative management.
So do you think there could be something on the MRI in this case that would push you to change your initial management? Not
necessarily. I think this is a insight into practice patterns a little bit to some degree, and I think a lot of the patients that I see that have this, and again, this probably isn't necessarily the right reason, but they're expecting MRIs and they're expecting to categorize it a little bit better. I do think an MRI is probably going to give me a little bit better of an idea how I can counsel them with regards to the success of non-operative management on this.
Okay, any other thoughts? Would you guys get an MRI?
I would get an MRI. I would, just because of the cystic change. One, for documentation. You know how this is going to progress. You don't know for sure. I mean, it's a high likelihood that it may resolve on its own if it's stable, but you want to know for sure if it's stable, how much fluid actually goes behind the lesion, and future treatment should be determined based on interval change, I think.
Dr. Bubby?
Yeah, I think you're stuck with an MRI because parents would expect it. And even though most of us might agree on initial treatment is based on lesion size and skeletal age, parents would think you're incompetent if you didn't get an MRI based in 2017.
Yeah,
she's 12. You said she's 12?
Yeah.
And plus, you have time. I mean, to me, the key feature is she's young and her physes are way open. So you have time to do non-operative care. I think that the thing changes when their physes get close to closing. The biology is different, as we all know, and that Jeff pointed out.
Just one last thing, Adam. Probably the biggest differentiating thing for me on this is the fact that it's pain medially and not mechanical symptoms. I think that's an important component.
Yeah, definitely no swelling, no mechanical symptoms, no evidence of any loose component to it as far as something freely floating. I guess as an aside, the conversation with the parents is important, and I can see the expectation for MRI. This patient, I did not get it initially. I had no concerns that there was anything loose. She had no swelling, no mechanical symptoms. I didn't think it was going to change my initial management. And honestly, parents are just happy when you know about this process and you sound knowledgeable about it, has been my experience. And so I've seen plenty of people come in with a diagnosis missed. Sometimes it can be a subtle finding on X-ray. And as long as you kind of let them know about the natural history, everything we talk about, sometimes you can avoid it, but certainly it's practice dependent. And so here's one of the MRIs, and let me show you. Sorry, the clicker's just not consistent. I'm trying to pull up the second one. What's some thoughts on the other one while it's up, the coronal?
There's a coronal of the right knee. There is an area, just a lateral aspect of the medial femoral condyle that has an OCD lesion. There's changes in the subchondral bone. I don't see a clear layer of fluid behind the cartilage itself. And I think this is, overall, it's consistent with a stable lesion. But
yeah, so let's just do that. So everybody just votes stable or not. So you're saying stable. Jeff? Or sorry, either way.
This gets a little bit in between the two, so I would agree that the fragment's where it needs to be, but there's a fairly high fluid signal on that coronal view behind it, so I would say this is a partially stable. I know I don't like to go in between. But.
Well, does that definition help you guide your treatment, or are you going to do the same thing regardless if this is stable or unstable?
In this patient, it would not change it. I would do the same thing with regards to conservative management, and it would likely lead to the same operative intervention as well.
Okay, Dr. Bugbee?
Of course, the algorithm is skeletal maturity, size of the lesion's important too, and on the coronal it looks a lot bigger, it's got a cyst. And I'm a big, as you might imagine, a cyst guy. The presence of cysts in an OCD lesion suggests a much more ominous subchondral bone pathology, and you can see on the AP, on the x-ray, there's a cystic portion to that. I'm worried about that because that suggests the subchondral bone is not behaving properly, and that's why she's symptomatic and it didn't heal. So you see that big cyst anteriorly, which makes that lesion all of a sudden a lot bigger than you thought based on your x-rays, right? So this puts her, to me, in a different category.
Okay, so if you had to say stable or unstable, which one would you pick?
Unstable.
Okay, so what's your management for this patient?
She's 12?
12, yeah.
So you have to follow the algorithm that the pediatric orthopedist for juvenile OCD and give them 6 weeks of non-weight bearing and whatever,
go back
what
one,
Jeff
please?
said, yeah. So that's what you treat a kid. The arthroscopists have a tool, so they might scope it, but I'd say 6 weeks so parents and kid can get their head around it and go from there, but lay the crepe because
Yeah.
she's demonstrating that this is going to need active intervention. That's just a really angry OCD lesion with the big cyst and everything.
Yeah, so just to stay on time, would anybody disagree with the non-operative course for a period? No. So that's what she had. She was non-weight bearing and successful. She had no pain while she was non-weight bearing. As an aside, I'll modify weight bearing based on symptoms. So if they only have pain with soccer, they don't have pain with walking, I'll let them walk. If they have pain with walking, they're non-weight bearing. That's been my anecdotal approach to try to not completely ruin their life during that time, but we'll become more aggressive if that is not successful. Since that all failed, we got to the stage of performing an arthroscopy. And so can you go to the next slide, please? Well, I can tell you that, but I want to see what you think of this. Okay, can you hit for multiple things? Can you hit next again? And then I'm sorry, one more time. So let's say that that was your MRI. This is the diagnostic arthroscopy. What are your thoughts at this time?
I mean, based upon your probing there, it doesn't detach. There's no area of partial detachment, at least based on that limited view. But once again, the real pathology is in subchondral bone. And if you're in the OR, I would be in the OR with the expectation of performing a definitive treatment. And my plan would be, do you want a plan?
Yep.
My plan would be to take the lesion down, bone graft the cyst, microfracture the base, and then fix it as we saw Dr. Cole do. And I would do a medial peripatellar arthrotomy.
Okay, other thoughts?
These are the really hard ones in my opinion, because this is a 12-year-old with a really high ability or a really high propensity to heal these with a bad-looking MRI, which most likely means that below that really good-looking cartilage is probably a fairly fragmented lesion that may or may not have a lot of bone or good bone on it. I think you need to give the patient a chance to heal this with a surgical intervention. At the same time, I get concerned with taking these down because they end up being so much worse than what it looks like right now, and I don't like going through great cartilage in a 12-year-old. So this would actually be one where I would antegrade drill it, and I would fix it in situ with 1 or 2 screws just to try and stimulate some healing, but I would not take this one down personally.
Okay, Dr. Bugbee?
Would anyone retrograde it and just try to deal with the subchondral bone and put something back there?
Can you hit the next slide, please? And then the one after that. So I find it hard on these patients. You're not in the OR, but I'm just telling you that probe, there was no trampolining whatsoever. There was no visible sign of this defect whatsoever. There was no potential for a cleavage plane to start, so you'd have to have fluoro in or something where you're really trying to figure out where you're going to really start unroofing it. And really it looked like subchondral cystic change more than instability based on the Desmet criteria for this MRI in my mind. So she underwent this retrograde drilling under fluoro guidance. And then can you hit the next slide? Because I think we're going to run out of time. I want to get to the next one. So this is what it looked like 3 months
Did
after.
you put anything in?
Nothing. So I just did the full non-weight bearing for 6 weeks. drilled it. You can really feel the sclerosis of those cysts when you're putting the wires in. You really know when you get through them. You'll feel like you're in the subchondral bone. You're not. You need to get through that. Don't plunge then, because then you could come out the cartilage. It's not the end of the world. It's a very small wire. But just for technique purposes, it'll definitely feel like you're going through. Keep the scope in the knee while you're doing it. Using the trick that Jeff had with the guide is certainly a great idea. And she was great. She was back at 3 months. Can you go to the next one, please? If everybody's okay, I'll do one more case instead of the Q&A session. Okay, so this is a 10-year-old. This defect looks a little bit worse than that last one. I'm not going to torch you. Go to the next slide, please. So I would still argue on that last patient that the MRI was, questionable when you indicate it. Certainly you have to finesse the situation. This one, in my mind, was a bigger deal. It was still all pain. There was no swelling, no effusion. But just the overall size of that and the fact it didn't just appear to be cystic changes was more worrisome to me. So I think we would all agree this is an unstable lesion in a skeletally immature patient. Anybody disagree with that? And so, again, an unstable lesion still has a chance of healing, even if skeletally immature, but there's a little bit of cystic change on that coronal. And so I guess my main question is, would anybody go directly to surgery, or we still all do the non-op management always in a skeletally immature patient unless the piece is moved?
Can I make a point about the CT scan? I think a CT this is the one area where CTs are still incredibly useful. On Brian's case, you would have picked up 3 different bony fragments that you might not have noticed on the MR. And this one too, it's got a buckle in it, and I'd like to know if that thing's in 1 piece or 3 pieces before I start deciding on all the other treatments. Tom's.
Yeah. I've treated several of these lesions in these young patients where it looks like it's a large clear area, and on MR you see this double density. The problem with the proton density is that the end plate looks the same as the calcified cartilage layer. So this is probably entirely cartilage, this fragment. That's my prediction. The only way you would not know that it's not entirely cartilage is with a CT arthrogram. So CT arthrogram here is incredibly useful because it's going to show you that that's probably just one big thick piece of cartilage with no bone attached.
What's the thickest cartilage you've ever seen in these OCDs? 'Cause
Almost 10
Yes,
almost 10
a centimeter.
millimeters thick.
Centimeter.
Yeah, just cartilage.
Just cartilage, yes. I've seen that more than once where it's 10 millimeters of cartilage, and it blows you away, but that's it.
So the other thing that can be useful, because that's a great point, which unfortunately I apologize I didn't put in here, is if you do have sagittal T1 images, it does show that much better than the proton dense does, but there's certainly nothing wrong with the CT either. That's obviously the best information. Can you go ahead to the next slide, please? Then one more. And then go ahead and hit play. There you go. So this is her knee. So I would argue this is very different than that last patient. It's more similar to what we just saw Brian operating on. And you can see that there is that plane there. You feel much more comfortable of where you're going. Go ahead and go to the next slide. Go ahead and hit play. Actually, go to the next slide again. I know we're running out of time. Can you go to the next slide, please? So in this setting, we unroofed it, as you saw. I have to say that, so first of all, I agree with Dr. Minus. This really was probably multiple pieces underneath. I didn't feel so confident that I could get this whole thing unroofed in a way that I would feel good about putting it back down. I thought the more that I developed a cleavage plane, the more I was going to be concerned about what I was looking at. And so I actually was able to get an elevator underneath, as well as that same drilling device that you saw with Dr. Cole, and preparing it all through just a small incision there, essentially through the cartilage surface. And then go to the next slide, please. I'll see what you guys think here. So I put screws in to fix this one because I thought this was actually unstable. And then go to the next slide. And I was not happy with my overall orientation. So this is, oops, go back one, please. And so this is what I did. So you can see that just like Dr. Minus was mentioning, that big screw was just below where the visual cleavage plane was. And I thought I was right at the top of the defect. And then I get in and I do the fluoroscopy, and I see that was actually the middle of it. And so the top piece was more cartilage, so I did retrograde drilling to try to address the rest of that. So what are you guys' thoughts? Would you have done anything differently, or?
So I think first it's important to note that this is a lateral defect, which is very different than a medial. They just tend to be very different actors and really big downsides for people. So just going back to the non-operative, I will watch these patients a bit closer, because if they do happen to get an unstable part, that lateral compartment can go downhill very quickly. With regards to the operative technique, the only thing I would change is that I actually use a standard screw, because I like the head when you're really grabbing a lot of the cartilage as opposed to the variable angle. I just feel like I can get a better compression on it.
Yep. Any other thoughts about that?
No, I like the hybrid approach. I wouldn't have thought about it.
It's not, I don't even know when I've ever done it before, but this one really fooled me, and when I looked at the images, I didn't want to leave that part unaddressed, and I couldn't put another screw in it.
Jeff's point is well taken on the lateral side. Fragment excision of these big ones is not as benign as the medial side, because that thing can destroy the lateral meniscus, and then you're back to like what we saw this morning. The only thing worse than this is that without a lateral meniscus. And if you take the piece out and leave a big defect, or that screw is proud and it fragments and you don't take it out and you destroy not just the plateau, but you lose the lateral meniscus, that's a really bad problem, because a lot of these kids are in valgus too, right? So then you've got a meniscectomized cartilage lesion in a valgus knee, and they started with a JOCD. So do no harm.
Yeah, great, thank you. So my one of the last two cases was essentially what Dr. Cole just did live, and I had another one where I excised an extremely large piece. I can just tell you that one had a gigantic hole in the condyle. It was about 60% of the kid's condyles, and he's 16 years old. He's still 8 months out with no pain, no swelling. X-rays haven't advanced, and I haven't put a graft in. I did, yeah. Yeah, we'll see how that goes. 8 months. Okay, any other questions or thoughts from the panel or the audience before we move on? Okay, great. Thank you very much.